Hi, and welcome to CFHI Foundations of Global Health Practice. I'm Dr. Jessica Evert, the Global Medical Director of Child Family Health International, and it's wonderful to join you today. We're going to talk about the conundrum of colonization in global health education and wider programmatics. Today, I kind of want to unpack what is colonization, how does it show up, and next time we'll talk about some of the remedies, so stay tuned. Colonization of global health practice has a lot of different definitions. One of my favorites that I think is slightly simplified but easy to identify is when there is a disconnect between the geographical realm of action and realm of power, meaning that power is centered in one geographical location and the actions or activities are centered in another. There's other definitions that bring into scope the broad strokes of power imbalances, subjugation, exploitation. One definition of colonization in global health is that one group of people have the power to dominate, subjugate, or exploit another group or groups of people, thereby enabling the misappropriation and extraction of resources in a large scale and systemic manner. Another definition calls for the recognition that it's an economic, social, and political system that relies on the principles of cultural hierarchy and supremacy as a justification of domination of the other. Lastly, there is the definition that colonization and colonialism in global health is the historical and ongoing dynamics where powerful nations or institutions exert control and influence over less powerful regions in the matter of health. This includes resource exploitation, imposition of Western biomedical models without context-specific modification, controls over health policies, perpetuation of health inequities, and unethical medical practices, dependency on external aid, and cultural insensitivity. So as we consider what is colonialism and global health, I want to talk about ways that it shows up and that we can see it. There's a variety of different terms that I find pretty helpful as we think about how colonization and colonialism show up, and I'm going to go through each one, and I want you to reflect on ways this shows up in your institution or in your work or your educational process. The first is called epistemic injustice. Epistemic injustice is when different ways of knowing are not honored or are devalued. There's two subtypes of epistemic injustice. The first is testimonial injustice, and that's when someone's knowledge or testimony is discredited due to prejudice. So when we think about unconscious bias and how we are socialized in terms of the value of knowledge and ways of being, in terms of the global north and the global south, or high-income countries versus low-middle-income country, it is very common that knowledge and testimony from low- and middle-income countries will be discredited due to unconscious bias and prejudice. The second subtype is called hermeneutical injustice. And this is when a community lacks the conceptual or interpretive resources, often due to that colonialism and suppression, to make sense of their own experiences in a dominant framework. Meaning that a lot of the frameworks in global health education and practice are coming out of the global north or high-income countries, universities, etc. And we create these frameworks to try and help people have shared understanding and try to help people engage in the same spaces and conversations. Unfortunately, when we create frameworks that have not been co-created with our collaborators, our colleagues, and leadership from low and middle income settings, then we create frameworks that are not accessible. And we then invalidate others' experiences and ways of knowing because they're not working in the frameworks that people from high income countries are saying are the frameworks to use and are really a defined reality in that way. The second way that colonialism shows up in global health education and practice is called the credibility deficit. The flip side of this is credibility excess, but credibility deficit is defined as members of the dominant groups who harbor prejudices and biases that lead them to discount the knowledge held by members of marginalized groups and their credibility as knowers. Credibility excess also happens where those who have been in the historically dominant or majoritized groups are given excess power, credibility, influence that does not align with their actual level of expertise, knowledge, or context-specific experience. Credibility excess can be rooted in historical patterns of social relations such as racism, sexism, and colonization, in which one social or epistemic group credibility excess comes at the expense of a marginalized group's credibility deficit. Meaning that oftentimes people from high-income countries or institutions in high-income countries will be given credibility as experts, and their advice, their ideas, their frameworks will be followed. And that actually takes away from the expertise that is honored and recognized from lower income settings. The next concept that I want you to noodle on is epistemic extraction economy. Epistemic extraction economy is when there's a reoccurring process in which knowledge produced in low and middle income countries is sourced, recontextualized, and valorized within high income countries' institutions. You will see this very often in research, where research done in low and middle income countries is valorized as the product of and celebrated coming from high income country institutions, often universities. And so this is an extractive process where universities from high income countries are utilizing research frameworks, communities, subjects in low and middle income countries and claiming that the results and the impacts are all their own, when in actuality there is shared credit, and if anything, there should be disproportionate credit given to the inputs and context of the low and middle income country setting. Another way that colonialism shows up in global health education and practice is called discursive exaggeration. Discursive exaggeration is when there is rhetorical magnification of certain ideas or actors within dominant narratives used to reinforce hierarchies of power, legitimacy, and knowledge. Meaning that there is often exaggeration of the role of institutions and individuals in high-income countries in all global health projects, initiatives, and even educational endeavors. The next concept I want you to think about is called outgroup homogeneity bias. Outgroup homogeneity bias is when there is a perception that outgroup members, those that are positioned as inferior, are more similar to one another than those who are positioned as superior in-group members. This happens oftentimes when there are partnerships between high-income country institutions and low-middle-income country institutions or communities, and the narrative is such that it seems like those who are partners, the individuals, right, are representing everyone's interest in the low and middle income country setting. So oftentimes there's homogenization of the low and middle income country community that does not exist when discussing the high income country stakeholders. The next concept is called the oversimplification cause fallacy. There's a lot of complicated words. It's also called the reductive cause fallacy or causal oversimplification. This one I find extremely common, particularly in global health education, as we try to teach about complex phenomenon in a way that is easily digestible and explainable. So oversimplification cause fallacy was really characterized by psychologists, and what they define it as is when a complex phenomenon is attributed to a single cause, ignoring multiple interacting factors that actually produce it. This includes reductionism. So reductionism is when we simplify multi-layered realities into one-dimensional explanations. The second subtype is causal distortion, which is when we suggest a direct and linear cause-effect relationship that doesn't really exist. The third type is erasure of context. This is where we're talking about a current-day reality, but not discussing the historical, political, or systemic factors that have led to that reality. And then the fourth type is moral or ideological bias, which is where we use this bias to reinforce a preferred worldview or justify power relationships. This is done commonly in global health education and practice, as there is generally almost a uniform discounting of expertise and abilities that exist in low and middle income countries. And so therefore, we oversimplify and have ideological bias about who's able to do what and who has the answers and who is going to produce the solutions. The next concept I want you to think about is generational epistemic drift. Generational epistemic drift is when there is a cohort by cohort shift within low and middle income country institutions that normalize external paradigms and displace locally anchored methods. This will happen oftentimes when there is like twinning of institutions in low and middle income countries, institutions in high income countries, in which the frameworks from the Western or high-income country through theoretical models as well as processes are valued, and there is an encouragement that low and middle-income countries become more and more like their high-income country counterparts. So I want you to think about these ways that colonization and colonialism show up in global health education and practice. This includes epistemic injustice, the credibility deficit, epistemic extraction economy, discursive exaggeration, outgroup homogeneity bias, oversimplification cause fallacy. And we're going to talk more next time about how we counteract these realities and we decolonize global health education and practice. Thank you for joining me today.